This is a symposium sponsored by Sandoz about the drug tacrolimus adport, a generic form of tacrolimus. I'm going to talk about optimization of tacrolimus in renal transplantation. Now, we all know that the basic regimen in a transplant patient usually includes 3 drugs. The first drug is usually a CNI or calcineurin inhibitor, or less commonly a mammalian target of rapamycin or mTOR inhibitor. The second drug is an anti-metabolite, mycophenolic acid or MMF, folate mofetil, or less commonly, sometimes in maintenance azathioprine, or also mTOR inhibitor if CNI was previously used, with or without corticosteroids. But by far, the most common regimen used is tacrolimus plus MMF or MPA plus or minus corticosteroids. It's used in 90% of cases, and this has been the case after multiple trials, including this meta-analysis that pulled together over 30 trials that found that steroid-resistant acute rejection is less common with tacrolimus compared to cyclosporin. But tacrolimus, as cyclosporin, has a narrow therapeutic index, and levels should always be kept at an optimal level. Low levels would lead to acute rejection, or even more dangerously, subclinical rejection that leads ultimately to chronic kidney disease, chronic antibody-mediated rejection, and eventually loss of the graft. While high levels would lead to infection, malignancies, metabolic side effects like hypertension and post-transplant diabetes, as well as CNI toxicity, also leading to loss of the graft. So again, our aim always in managing transplant patients is to maintain the level in the narrow therapeutic index through reactive adjustments to limit toxicity while maximizing efficacy. If you want to understand how the drug works in the body of the patient, we give a dose, then the pharmacokinetics, the absorption, the metabolism, the distribution and excretion lead to a certain concentration in the blood, a concentration at the site of action, and then the pharmacodynamics, or the way the body reacts to the body, gives the desired effect. In transplant patients, we monitor the concentration in the body by therapeutic drug monitoring, and we monitor the effect by measuring creatinine repeatedly, by calculating estimated GFR, by assessing the resistive index by Doppler ultrasound, and also that's the effect, the desired effect, and we should also monitor the undesired effect in the form of adverse events. But although therapeutic drug monitoring is the most commonly used, it is suboptimal. There is interpatient variability. So at the same drug level, in some patients there may be sufficient immunosuppression, and in others there will be low immunosuppression. And at the same time, at the same drug level, some patients may develop side effects while others will not develop side effects. Mainly because we assume that the concentration in the plasma mirrors the concentration at the site of action, which is not always the case. Sometimes the local exposure is more or higher, and it's actually more important than the systemic exposure, but we cannot measure the local exposure. So trough levels are the only solution we have, and we have a form of reactive medicine where we use trial and error to correct the level. Another problem with tacrolimus subscription or prescription is that there is huge intra and inter-individual variability, and we have to understand them to optimize the therapy in each patient. These intra and inter-individual variability are mainly caused by the tacrolimus pharmacokinetics. There is a biological effect of treatment differs between individuals, as we said. That's why we need continuous therapeutic drug monitoring. Why is there variability? First of all, they found that the oral bioavailability is extremely variable. Sometimes it's 4% up to 89% because of variable absorption, variable metabolism, and even the metabolism can happen in the gut as well as in the liver, and they give multiple metabolites. Some of them are active. Also, in the blood, it is extensively bound to RBCs and plasma proteins, and they can be affected by the presence of anemia or the presence of hypoalbuminemia. Therefore, there has been a rise in the term of clinically significant variability within an individual, where there is alterations with over and under exposure at the same dose. The patient who takes the same dose once his trough level is high and once his trough level is low. And this change between over and under exposure leads to alloimmune activation in the periods where he has low exposure, and toxicity and low in the periods where he has over exposure. And they usually calculate intra-patient coefficient of variation, and they say that patients with high intra-patient coefficient of variation need closer monitoring. So what are the factors that affect variability in patients, and what are the factors that affect prescription, and how can we better optimize the treatment? Now, the first thing, as we all know, is drug-drug interaction. There are multiple drugs: antibacterials, calcium channel blockers, antiretroviral, antifungal, anticonvulsants, anti-inflammatory, antiarrhythmics, anticoagulants, antimalarials. Over 707 drugs have been found to interact with tacrolimus, either by impacting absorption, distribution, metabolism, excretion, or also by affecting the gut microbiota, which we'll know later affects many drugs that, and we do not accommodate for it. There is also, in patients with transplantations, they're usually taking multiple drugs, and the polypharmacy increases the risk of drug-drug interaction. So what can we do to prevent this variability and its effect on the treatment? We always should monitor tacrolimus when starting a new treatment, and we should avoid drugs, if possible, known to cause interaction. Another thing is alcohol and food interaction, and although the majority are moderate to minor, it has also been found that taking concomitant ingestion of food with tacrolimus decreases the bioavailability. That's why we always recommend that patients take it on the fasting state. And also, it's known, but thank God we don't use it a lot. Grapefruit and juice, they inhibit the activity of cytochrome P450 enzymes that are responsible for the metabolism of tacrolimus, and they may increase tac exposure. Another recently found interaction was with turmeric and ginger, الجنزبيل والكركم. They are commonly prescribed, and now turmeric has some antioxidant effect and may be taken by the patient as a supplement, and it may affect the tacrolimus level. Demographic predictors also affect the drug level. Age increases the concentration. Gender has weak association. In blacks, there is lower tacrolimus concentration, so we need to give higher doses. And in Asians, there is higher tacrolimus bioavailability, so we need to give lower doses. Elderly are especially a fragile group. They have reduced immune response, so they have lower risk of acute rejection, and at the same time, they have higher risk of immunosuppression-induced infection and malignancy. They usually have comorbidities, poor cognitive abilities, memory, taking multiple drugs. They are more susceptible to tacrolimus toxicity, especially nephrotoxicity and neurotoxicity, and they are commonly slower metabolizers. We should always start with a lower prescribed dose, and we should target a lower tacrolimus level. There's also pharmacogenetics have multiple role in determining the tacrolimus level. Multiple drugs are associated with absorption, with efflux of tacrolimus and its distribution in the tissues, and there have been multiple studies. Even there were studies which determined the mutations that cause rapid metabolism of drugs, and there were trials that tried to use pharmacogenetics to prescribe the appropriate dose, but however, in these trials there was no effect on the number of patients reaching therapeutic tacrolimus concentration, and there is no effect on the clinical outcome, so it cannot yet be used to prescribe the adequate dose, but we should know that it is an important cause in the variability between patients. Gut microbiota and its effect on drugs in general is a new branch in pharmacology called pharmacomicrobiomics, and there is some evidence that microbiota may affect the tacrolimus absorption. It also some gut bacteria may metabolize tacrolimus to active metabolites. That's why antibiotics given, even if they do not directly interact with tacrolimus, they may interact with the gut microbiota and affect tacrolimus level, and that's why we should always only prescribe antibiotics in transplant patients when indicated, because we cannot predict how they will affect the gut microbiota and how this will affect the drug level. There are other factors contributing to tacrolimus intrapatient variability: gastrointestinal disturbances. Patients with severe diarrhea, because of the rapid transit time, usually have increased absorption and increased level during the period of severe diarrhea. As we said, it is heavily bound to RBCs and proteins, so low serum protein and low hematocrit may lead to increase in the free fraction and increase clearance and decrease the tacrolimus blood level. So any patient, for example, with acute blood loss, his tacrolimus level should be monitored. There is circadian rhythm, though we should ask the patient to measure the blood level at the same time every time. And sometimes also there is intrapatient variability because use of different labs and assays. So when we adjust the dose of drugs, it's important for us to make sure that the patient is following or is measuring the tacrolimus level in the same lab using the same assay. Another group that has specific problems with tacrolimus is, or in the prescription of tacrolimus, is the fast metabolizers. They metabolize tacrolimus very highly, so they need higher doses to maintain the target trough level. But higher doses, although they will maintain good trough level, these patients have high Cmax or maximum level, the 2-hour level, and these levels lead to increased risk of adverse events in comparison to slow metabolizers. And this high load rate of tacrolimus clearance, so they increase high risk of adverse events, and at the same time, because at the end of the day they have very low levels, they are at increased risk for rejection. So they are having both the side effects and the acute rejection. And there is one alternative strategy that they found to be useful in these patients with to shorten the dosage interval. So if the patient is, for example, taking 10 milligrams per day, he may take them as 332 or 333 every 8 hours to achieve the desired trough with lower peaks in the level. And of course, the fast metabolizers have a very big problem of the higher cost, and this higher cost leads to less adherence. And maybe non-adherence is a very common and very problematic issue in transplant patients. Now, especially in the young individuals, common challenge, and it may cause intrapatient variability. Sometimes when a patient comes with a low level and you ask him, have you been taking the drug correctly? He tells you, I sometimes forget, I take it on wrong times, the treatment I dispensed was over and I did not have time to refill the prescription. القرار خلص وانا دلوقتي بحاول ان انا اقسم الدوز عشان ما ناخدش الدراج خالص. فبيبقى في مشاكل كتيره بنشوفها وخصوصا في اليونج ايج. Actually, it's recommended in the transplant patient, especially in at every visit, we make sure that the patient is taking his medications adequately and correctly and is not skipping doses. Now, in general, patient compliance and adherence له factors كتيرة بتأثر فيه. منها patient-centered factors, the younger age because of non-compliance and the older age because of memory problems are less likely to be adherent. في psychosocial factors, في presence of depression, presence of anxiety, presence of peer pressure. أو برضو البيشنت اللي هو اليونج اللي هو رايح الكلية مش عايز ياخد الأدوية قدام زمايله. Side effects of the drugs, the therapy related factors. We usually do not ask the patients about the problems, but a lot of patients, especially in the young, because of the acne caused by steroids, they skip steroid doses. Sometimes because of the tremors caused by tacrolimus, they may skip tacrolimus doses. So it's important to ask them about side effects. And sometimes patients have side effects because of another thing, and they relate them to the drug, and they stop the drug because of this. So we have to always ask about the side effects and to try to ameliorate them as much as possible. ويمكن اكتر حاجه عندنا هي الكيس هيلث كير سيستم فاكتورز. احنا عندنا يا اما البيشنت بيديسبنس من التامين يا اما من الكوميسيون، ومشكله الكوميسيون ان القرار مش هيكفي، بيروح المستشفى بيقعد كتير لغايه لما يصرف القرار. ممكن ميعاد صرف الدواء يجي في اجازه رسميه فيقعد كام يوم من غير القرار، فبتبقى مشكله قوي كبيره جدا في البيشنتس دولت، وبتيجي على ان هو بينكريز الكوست، والبيشنت اللي عنده لو انكم بتبقى مشكله فيه. طبعا احنا برضو من البروبلمز اللي كنت عايزه امنشن برضو اللي هي الليترسي. البيشنتس الاديوكيتد بيبقوا وخصوصا if we explain the importance of the drugs and the side effects of the drugs and how to overcome them بيبقوا more likely to be compliant وده جزء مهم قوي في الكير بتاع البيشنت بتاعنا. الكوست اند كومبلاينس يمكن هي زي ما قلنا مشكله كبيره قوي في قطاع كبير من البيشنت. هي in general cost is a problem for chronic diseases لان treatment is lifelong والبيشنت بيبقى قدامه طب انا اكل واكل عيالي ولا اجيب الدواء اللي ناقص مني وخصوصا لو البيشنت ما عندوش انشورنس كفر. فالبور ميديكيشن ادهرنس بيليد تو بور هيلث اوتكمز وبالنسبه لنا البور هيلث اوتكم اللي هو هيحصل ريجكشن ده البيشنت هينقل من العلاج الاميونو سبريشن للغسيل فبرضه ده هينكريز السيرفيس يوتيلايزيشن وهينكريز الهيلث كير كوست وهينكريز الكوست باس تو ذا بيشنت. فاحد الطرق ان احنا eliminate this increased cost is to use low cost generics بس طبعا مش اي جينيريك واحنا زمان على طول كنا في العهد اللي كان فيه جينيركس للسايكلوسفورين والام ام اف من الهند كنا بنقول للبيشنت اوعى تستخدمهم لان هم دولت هيبقوا خطر عليك. لكن هو الجينيريك برودكتس ان جنرال هم they must have the same active ingredients, the same dosage form, the same route of administration, the same strength بس هم طبعا ممكن يكونوا different في الشيب في السكورينج في الريليس ميكانيزم في الباكجينج في الاكسبيريشن تايم وطبعا هم بيبقوا much cheaper عن الاوريجينال فورم. بس عشان اي جينيريك نستخدمه لازم يثبت البايو ايكويفالنس اللي هي ايه البايو ايكويفالنس؟ the absence of significant difference in the rate and the extent of the active ingredient or active moiety in pharmaceutical alternatives becomes available at the site of drug action when administered at the same molar dose under similar conditions in appropriately designed study. يعني هدي الدواء وغالبا بيبقى في نفس البيشنت بيبقى في فتره على الانوفيتور دراج وفتره على الجينيريك دراج وهقيس بنفس الجرعه باتشيف دراج ليفل قد ايه سواء تراف ليفل او اريا اندر ذا كيرف على الجينيريك وعلى الانوفيتور دراج في نفس البيشنت عشان اشوف اذا كانوا هيدوا نفس الايفكت ولا لا ولازم ان هو تبقى الماجوريتي اوف بيشنتس اتشيف من 90 ل 110%. يعني لو هو بياخد دوز 3 مللي جرام والتراف ليفل بتاعه نقول 8 يبقى هو المفروض ان هو يبقى 8 بلس اور ماينس 0.1 لكن لو هو في نفس الدوز بيدي اقل يبقى هو كده مش بايو ايكويفالنت. وهو الساندوز جينيريك التاكروليموس اللي هو الادبورت هو approved بايو equivalent وعشان كده هو approved by the FDA و approved by the EMA اللي هي اليوروبيان برضه بادي اللي بتابروف الجينيريكس وبتابروف الدراجز ان جنرال فور يوز فهو اثبت من زمان ان هو بايو equivalent to Prograf in kidney transplant patients. وحتى بعد البايو equivalence احنا برضه قلقانين شويه بس في ستادي في ميتا اناليسيس اتنشرت من سنتين كانت جابت 17 ستاديز استخدمت كلها approved generic tacrolimus يعني generic tacrolimus اثبت ان هو بايو equivalent في ليفر وكيدني ترانسبلانتيشن كان 5 ستاديز في الليفر ترانسبلانتيشن 11 في الكيدني وواحده في ليفر وكيدني وكان فيهم 1400 بيشنت. وسواء الستاديز اللي استخدمت الليفر ترانسبلانتيشن او الستاديز اللي كان فيها كيدني ترانسبلانتيشن اثبتوا ان مفيش increased risk او مفيش difference في الريسك of biopsy proven acute rejection سواء البيشنتس خدوا الانوفيتور تاكروليموس او الجينيريك تاكروليموس. ولما قسموا الستاديز برضو للستاديز اللي بدات دينوفو يعني من اول الزرع هم استخدموا الجينيريك تاكروليموس والستاديز اللي كانوا على انوفيتور تاكروليموس وقلبوا للجينيريك تاكروليموس لقوا برضو ان في الكونفرجن ما فيش فرق في الريجكشن لكن اكشولي الناس اللي بداوا دينوفو على الجينيريك يمكن عشان better compliance they had less biopsy proven acute rejection. وبرضه الستادي الميتا اناليسيس ديت بصت على البايو ايكويفالنس اللي اتقاس في الستاديز وسواء الاريا اندر ذا كيرف اللي هي بتقول الدراج ليفل اوفر ذا 12 اورز اخباره ايه والسي ماكس اللي هو ال 2 اور دراج ليفل لقوا ان في بايو ايكويفالنس وما كانش في فرق بين البايو ايكويفالنس بين التاكروليموس الجينيريك والتاكروليموس اليوست. ويمكن في امريكا في ستاديز كتيره ان هو بعد الابروفل اوف الحاجات ديت ان هم بداوا يشيفت معظم البيشنتس بعد ما كان 100% على الانوفيتيف دراجز سواء في التاكروليموس او في المايكروفينيت موفتيل بدا ان هو اليوز اوف ذا انوفيتيف دراج او الاوريجينال دراج يقل واليوز اوف the approved bioequivalent generic drugs يزيد لدرجه ان هو وصل 80% سواء في المايكوفينوليت موفيتيل او في التاكروليموس. من 2009 ل 2013 النسبه ديت زادت من 0 ل 80%. ويعني في ستادي مور ريسنت كمان بينت ان اليوز اوف جينيريك تاكروليموس او جينيريك مايكوفينوليت موفيتيل قدر يقلل على الميديكير اللي هي تعادل برضو عندنا التامين او الكوميسيون، ان هي قدرت تقلل من 50% من الدراج كوست، والبيشنتس اللي بيدفعوا من جيبهم قدرت تقلل من 60 ل 70%. طبعا احنا الدوله ونفقه الدوله والتامين اولى بال 50% دولت، وبرده البيشنت وخصوصا لو هو هيجيب فتره من العلاج او لو هو فاست ميتابولايزر وبيحتاج جرعات كبيره هيبقى هو اولى بالنسبه ديت اللي برده مش هتاثر على الاوتكم. طيب in conclusion how do we optimize the tacrolimus level؟ اولا احنا حتى الان مفيش طريقه ادق من الثيرابيوتيك دراج مونيتورنج في ان احنا نفولو التاكروليموس ليفل، فهو ما زال ان احنا محتاجين ان احنا نقيسه ريجولارلي، وخصوصا في العيانين اللي عندهم هاي انترا بيشنت كوفيشنت اوف فاريشن. يعني البيشنتس دولت وي هاف تو ايدنتيفاي ذم في العيادات ان هو ده العيان اللي مره تحليله عالي ومره تحليله واطي، واقلله الدواء يقل واقلله الدواء يحصل يدخل في توكسيستي. العيان ده بيبقى محتاج كلوزر مونيتورنج، فحتى لو هو الامور كويسه ده نعمل له مثلا مانثلي كونتينيود مونيتورنج. وكمان في الباست ميتابولايزرز we need to closely monitor them، خصوصا ان هو هيبقوا difficult to achieve التارجت ليفل، وفي نفس الوقت هيبقى في عندهم high incidence of side effects. We always have to educate patients about the importance of drugs والfoods. وبرضه يعني يمكن اكتر حاجه عندنا مشكله فيها، يعني سهل ان احنا نبص على الانتراكشنز بس، الحاجات اللي هي الهيربل وحاجات التخسيس وحاجات اللي هي السبلمنتس ديت اللي فيه مشكله فيها، وبرضه ممكن تعمل لنا انتراكشن والبيشنت ما يشتكيش منها او ما يبلغناش ان هو مثلا بياخد كركم اللي هو لقوا ان هو له ايفكت على الدراج. We have also to monitor closely whenever we're prescribing a new drug whenever there is diarrhea، ان احنا نقيس خصوصا لو الدايريا ديت protracted وان هي سيفير، ان احنا نقيس الدراج ليفل اثناء الابيزود اوف الدايريا وبعد الدايريا. لو حصل acute انيميا لاي سبب، لو في هايبوالبومينيميا، لازم ان احنا closely نمونيتور الدراج. في الاخر اي نعم احنا we should keep the drug level in the narrow therapeutic index، بس برضو يعني احنا في اسكندريه احنا الاندكشن بيبقى التراف ليفل من 8 ل 10، وفي المينتننس بيبقى من 5 ل 8. ف we should keep the level at the higher end in patients with high immunological risk with previous rejection episode, and we should keep it at the lower end of the trough level في patients اللي have side effects and patients who زي مثلا post transplant diabetes او patient who are elderly, and we should continuously monitor them. واهم حاجه ان احنا we have to attack non adherence. non adherence اهم حاجه في patient education about the value of treatment. برضو يعني احنا بنشوف كتير ان هو اللي هم الاطفال او التين ايجرز، وخصوصا لما حتى يبقوا 20 والاهل برضو هم اللي بيقولوا لهم ياخدوا الدراج، بس هو البيشنت نفسه لازم يفهم اهميه الدراج ديت عشان هو ياخد يبقى فيه patient engagement، ان هو البيشنت نفسه هو اللي يهتم ان هو ياخد الدراج. ومن الحاجات المهمه قوي برضو ان احنا we have to review and address the side effects ونحاول ameliorate them with other drugs، لان دي برضو من الحاجات اللي ممكن تخليه ان هو non compliant. ويمكن اهم حاجه ان احنا نيوز الجينيركس اكتر في الحالات اللي عشان نقلل الكوست سواء على البيشنت او على الهيلث سيستم، وده هيمبروف الادرنس في حالات كتيره جدا. شكرا جدا ليكم.